So good morning, everybody. We're working on some minor technical issues. So this is Kelly Branch. I'm very happy to introduce Betty Ashine. I've been mispronouncing her last name for I don't know how long. Anyway, we are so happy to have Betty here. Betty comes to us from Duke, where she went to undergrad and medical school, and then went to Emory for master's in public health, and has been one of our fellows here. Is now a third-year fellow and will be an emerging fellow going out into private practice, potentially somewhere in Florida. Still working on that a little bit. Woohoo! We're sorry to lose her here, but Florida is going to gain a wonderful cardiologist. And so Betty's going to be talking about beyond statins, current and emerging alternatives to lipid lowering. And just so everybody knows, she's a big Duke basketball fan, despite all of the difficulties we know that Duke has in order to retain college coaches. But anyway, maybe they can do better this time. Right, exactly. Okay, so Betty, please.
Thank you. All right, good morning, everyone. As I'll be talking about current and emerging alternatives to lowering lipids with non-statin alternatives. And if you get the chance, log into Poll Everywhere with the link at the bottom and the QR code, and the option will pop up when we get to the appropriate slide. I have no disclosures. So my objectives are for us to discuss the limitations of statin and the management of dyslipidemia, as well as available alternatives that are currently FDA approved, and also what to kind of describe the investigational approaches that are going on. So I'm going to start off with the historical context and talk about some challenges with statin use. And before I do that, I'm going to start at the molecular basis so we can understand how we got to the targets we're at. So I'm going to talk about apolipoproteins. These are type of proteins that bind with lipids to form lipoproteins. So once they're bound, they're able to facilitate transfer across tissues. So we have the insoluble type and the soluble types. The ones we tend to focus on for drug therapies currently have been the insoluble types. So specifically, ApoB containing lipoproteins. These tend to be the atherogenic ones, and but we're still keeping in. I want you to still keep in mind the soluble types. And this is kind of a diagram showing on the bottom the different ApoB containing lipoproteins, and these are typically what we think about as the more atherogenic ones. So in terms of ApoB lipoproteins and the link to atherosclerosis, there's this hypothesis called response to retention. So when ApoB lipoprotein, or ApoB, I'll call it here, particles pass through the arterial lumen, they can get trapped. Once trapped there, the longer they're there, they can either transform, or they can also just persist there. In that combination, they will interact with the arterial matrix as well as macrophages and lead to harmful inflammatory responses. And that's what those responses lead to, either the propagation, the creation and propagation of cholesterol lesions. And that's what we mean that the response to retention. And then back, just to highlight again, ApoB lipoproteins, think of them as the sticky atherogenic ones. Of these, they're LDL, lipoprotein A, IDL, and VLDL. So with a lot of the therapies we do have been focused primarily on LDL because they make up about 90% of the ApoB containing lipoproteins. And you might see in my slides the term LDLC, which means cholesterol that's been carried by the LDL. So LDL, I'll call it LDL here, has been shown to have a causative effect of ASCVD by cardiovascular disease by multiple studies. They've been Mendelian randomization, genetic analysis, observational FD studies, as well as RC randomized controlled trials and animal experiments. So that's why a lot of our focus has been on that. So today, what I'll try to do is try to discuss all these FDA-approved targets. This will seem like a lot, but we'll go through it slowly. And the first one I want to start off with is statins. So in terms of its mechanism of action, it inhibits HMG-CoA reductase, which is an essential enzyme in the metabolism of cholesterol and the synthesis of cholesterol. And by inhibiting HMG-CoA, what statins can do is they decrease the intracellular cholesterol, which leads to increased LDL receptor expression, which eventually is a decreased concentration of cholesterol in the plasma. And there have been studies on statins that started, and this show you like the historical context. They started like in terms of the placebo-controlled trial started as early as 1994, and these are ongoing, and they have led to our understanding of how statins have impacted cardiovascular outcomes. They've been meta-analysis that also showed that for every millimole of LDL that's lowered, you get about close to 20% decrease in major vascular event, coronary events, coronary disease events, as well, and also a 17% decrease in stroke and 20% decrease in all-cause mortality. And there's been an inverse relationship between LDL and cardiovascular events. So one thing I wanted you to take away from this presentation is that treat LDL as a toxin. The lower it is, the better it is, because of this inverse relationship. I want you to take a second to log into Poll Everywhere, and you can use a QR code or the link I provided. Right, and for some of you using Poll Everywhere for the first time, it may require you to just log into your UW account. It's just linking it. It's still an anonymous survey. And for those of you who are logged in, my first question I want to pose to you is, name a challenge you face after prescribing statins for patients. And you're welcome to respond multiple times. You don't have to only respond once, but just name things you, a challenge you have. So what you're seeing right now is, so far, it seems like misinformation is the biggest challenge for a lot of providers are facing. There's also, we're seeing on our word cloud, a lot of adherence issues, the adverse side effects, whether it's perceived or we see side effects as well. I'll just give it, we'll wait till about 10 people respond perhaps, and then we'll move on. Ultimately, it seems that the main thing is misinformation, which is the biggest challenge from like patient and provider relationship. So interest of time, I'm just going to move on. So the reason I bring this up is I want to talk about some of the limitations to statin use in our patients. So the first one I want to talk about is intolerance. So when patients say they're intolerant of a statin, that's going to lead to them not taking it. So that leads to non-adherence. So when we think about the term statin intolerance, at least by the National Lipid Association, what it's defined as is that there's a side effect, at least one or more side effect that's been associated with statin use that either improves or gets better with the discontinuation or a decreased dose of the statin. And to be called intolerance, patients should have tried at least 2 or more statins, and which at least one of them was at the lowest level dose. And the reason that's important is if a patient, say, is not tolerating a medication at the highest dose, that's something we would call complete intolerance. Sorry, at the lowest dose, they're not tolerating it. You might say, okay, even at the lowest dose with an alternate dosing of every other day, if they're having side effects that they attribute to the medication, call that complete. And then if they're able to at least tolerate a lower dose or alternative dosing, called partial intolerance. And the reason I bring that up is we always want, even if it's not at the dose statin that we want patients to be on, we still want them to be on some level of statin. Some of the side effects patients have mentioned have been myalgia, that, when they do, and so in studies, for example, in observational studies, that's been seen as much as 1 to 5% in randomized control trials, but in observational studies, they've been up to 5 to 10%. And then with myopathy, there's been about less than 1% of patients complaining or having issues of statins, giving them that. And rhabdomyolysis has been 0.001% is the incidence of that. The other things that people bring up are elevated liver enzymes or transaminitis, hyperglycemia and diabetes, which all of these that I'm listing are even more and more rare. And the other one that people bring up is confusion or memory loss. So this has only been seen in case reports. There have been 3 large randomized control trials that do not show that. I bring up these side effects to also mention what the prevalence is in observational versus randomized control trials. So in observational studies, all these side effects made up of 64 cohort studies, there were only 17%, there were about 17% of reporting of these side effects, whereas in randomized control trials with a placebo, there's about only 4.9% reporting of these. And this is from 112 randomized control trials. So I ask you, what is the reason for this discordance? And I'm going to go into that. So one partial cause is something I want to introduce, the concept called nocebo effect. So that means that there's nocebo effect relates to expecting a harm from therapy leading to the perception of the side effect. So there were these 2 key trials that were done, both one in the US and one in the UK, on N01 trials, which is that the patients served as their own controls. And in these trials, one Samson done in the US and the statin-wise done in the UK, when patients got statins, there was no difference in their symptom that they were reporting when they were on statin and placebo. What I liked specifically on the Samson trial is that they had a period in which there was a period patients would be on statins, a period they'd be on placebo, and a period of no medications. What they saw is when patients were on with getting medications, either the placebo or the statin, they might report a side effect, but when they're not taking the pill, they may not report that. So with nocebo effect, it's kind of almost saying patients, when they're taking the pill, expect the impact. So that's one of the things we've seen. And on these trials, they saw a lot of patients afterwards, a large proportion ended up continuing on that medication. So with this, just trying to focus on seeing if patients are having background side effects from other reasons, or is it like their perception and fear about these medications? Like, because the main thing we saw earlier is there's a lot of misinformation out there. The other challenge that we see is, patients are on statins, they're tolerating it, but they're not achieving their goals. So depending, and the guidelines we have in the US, we have the 2018 guidelines or cholesterol guidelines. We also have the expert consensus decision pathway that just came out in 2022 about the different goals we should be achieving. So when you have your patients on something they're not achieving their goals, that's another, you can have them a maximum tolerated, you can switch them, say, from atorva to Rasuva, but you may not be reaching the target goal for their risk profile. And the last one I want to talk about is residual risk. So about even patients that achieve their LDL goal on statins, there's still about 2/3 that end up suffering a major coronary event. While this could be from, say, poorly controlled diabetes, hypertension, other risk factors, the point I'm trying to make is that getting LDL to goal is not the only, it's not fully effective at lowering or really strongly diminishing. We have still a lot of patients that are having major events. And the reason I bring that up is more recently in the literature, there's been an interest in non-HDL. So the other ApoB containing lipoproteins as being possible causative or having a relationship to mortality and MI. So there's a study done in 2021 saying that it was increase in ApoB and increase in non-HDL that was linked to all-cause mortality and MI compared to unlike but not LDL. And this was in patients that are already on statins. So with, we talked about like some of the challenges we face with statins. So that's why I want to bring up what alternatives you have, or we have to use in our for our patients. So talk about some of the alternatives, and I'll just briefly mention we have both the 2018 guidelines and the 2022 expert consensus decision pathway. And the reason that came to be was that since 2018, there have been a lot of new drugs that are on our market that are FDA approved and have been shown to be effective at lowering cardiovascular events. So I'll kind of touch on a bit of these. So these are the targets, again, just to recenter everybody that I'll be discussing, and we'll go through it one by one. So the first one I'd like to talk about is ezetimibe. So trials have been going on regarding ezetimibe, right, from late, so from 2008 to 2009 period till currently. And the important one is the Improve It trial, which talks about outcomes in patients. So what is ezetimibe? So ezetimibe is a drug that helps inhibition of Niemann-Pick C1 LIPE1 transport in the small intestine. And then this has led to, with the drug alone, you can see an 18% decrease in LDL. And with in combination statin, there's been a 25% decrease. So with Improve It, what was done is in patients with recent ACS who are already on moderate intensity statin, the addition of ezetimibe led to these. I have this chart up here. What it led to is that you see the hazard ratio of 0.9, so about 7% decrease. So the primary outcome was cardiovascular death, MI, hospitalization for unstable angina, coronary vascularization, and stroke. And this medication is well tolerated in many patients. Some patients, a lot of patients tolerate, but you might have these rare patients that might mention some arthralgia, but that's not as common. The next one I want to talk about is the PCSK9 inhibiting drugs. And I focus on the term inhibiting because we're going to talk about two that have been studied. The first one, so with PCSK9, first, what is it? So this is a protein that is primarily produced in the liver. And what it does is that it binds to the LDL receptor. And in doing so, it signals that LDL receptor to be degraded, which leads to increase in the plasma concentration of LDL. So ultimately, PCSK9, the way to think about it is more PCSK9 in the system, more plasma LDL. So that's why they're now the first drug is I'm talking to you about is the PCSK9 inhibitor inhibiting a human monoclonal antibody. And this is the one we mostly talk about, we've been excited about for the past 10 years or so. And this binds to PCSK9, and by doing so, it decreases the downstream effect of it and leading to increase in LDL. By binding to PCSK9, it increases the clearance of LDL from the plasma. And this is the one thing to notice is a sub-Q regimen. The patients get their self-administered every 2 to 4 weeks. And I put in the side effects here, but really, it's really well tolerated by patients. So in terms of outcome studies that have been done, so the first is the Odyssey outcomes. So with this, it was looking at patients with recent ACS, who also had elevated LDL, non-HDL, and ApoB. And with the primary endpoint they were looking for was 5-point MACE. And what they saw, there's like a 15% relative risk reduction compared to placebo. And it's very striking how much, patients are already on statin. We saw that the LDL drops anywhere from 45 to about 58%. And even all-cause mortality is a 15% risk reduction as well compared to placebo. The second trial is on evolocumab, and it's the 48 trial. This looked at patients who had coronary disease, and this could be either MI, stroke, or symptomatic peripheral artery disease. And these patients who were on statins, and however, with LDL above goal, which is their LDL about 70, they found that there was about a 59% decrease, so almost 60% decrease in LDL on top of where patients were at. And as you can see, there's significant decrease in cardiovascular events in both the 5-point and 3-point. So with this, even death, MI, and stroke. So this is it's pretty exciting in terms of how much of an impact this is making. The other PCSK9 inhibitory drug I want to talk about is inclisiran. So how this works is that there's a small interfering RNA that targets PCSK9. So with the first one I talked about, the monoclonal antibody, what it does is it is inhibiting the PCSK9 extracellularly, while this drug is working in the intracellular level, so at the RNA level. So what it does is it blocks PCSK9 protein translation, so it's not being expressed. It's a type of, the way to think of it, it's a type of a gene silencing type of mechanism. So what it does is this ultimately leads to a decrease in LDL concentration. And the nice thing about this drug is that the way it affects its, the mechanism actually is that, so this small interfering RNA, it first binds to something called a silencing complex. And by doing that, that complex then binds to PCSK9 coding mRNA multiple times. So while the half-life of this inclisiran is not that long, the activity of the silencing complex is much longer, so you can have that effect for months. And the reason I bring that up is that with the earlier drug, with the human monoclonal antibody one, you are having to dose those patients every 2 to 4 weeks, versus with inclisiran, because the silencing complex can have its effect longer, you actually can end up dosing patients every 6 months. So in terms of important trials, so the trials that showed safety and efficacy of using inclisiran, these are the Orion trials. There was 10 and 11, and these were in patients with cardiovascular disease and elevated LDL. And in the US group that were studied on, there was about close to 51% decrease with an LDL, and about 46% decrease in the European and South African group that were studied compared to the placebo group. The one thing, unlike the first group of PCSK9 inhibitory drugs I talked about, this drug does not have outcomes data yet, but there's projected completion. Is the Orion 4 was projected to be complete in 2026 and 2027 for the Victorian 2P1. Like I mentioned earlier, after patients get to a maintenance dose, you're able to dose this medication every 6 months. The only difference is because this medication specifically has to be given by the provider or a clinician, the patient cannot self-administer. So while we're on that topic, how low is too low? So there was an article that just came out actually about a week ago, focusing on the association between achieving low LDL cholesterol levels and long-term cardiovascular and safety outcomes, analyzing the 4-year-old. And this was about 7,000 patients with stable coronary disease, and they're followed about 5 years. And what was seen is that there was a significant, with the lower the LDL was, so even as low as less than 20, the lower the 5-point MACE. So as well as there, and I have this chart right here. So on the left corner, you can see the red line is when LDL is less than 20, and the top one is if LDL is greater than 70. So the lower it is, like you can see the curve getting lower and lower in terms of the incidence rate of MACE. And the other thing is from a safety standpoint, if you have a lower, they didn't see any excess adverse event. So ultimately, the point is you can go as low as you want for LDL. It's actually ideal. Last drug I want to touch upon in terms of currently FDA approved, in this timeline at least, is bempedoic acid. And the study on this was mostly in the 2022 area, and it's the clear outcomes. So what is bempedoic acid? So this drug inhibits the ATP citrullinase lyase. So I have the diagram on the right to show you that it actually makes its inhibitory impact above where statins do. So statin would have been one down on the lipid synthesis pathway, but so bempedoic acid can decrease the ATP citrullinase upstream the cholesterol synthesis pathway. And in studies, it's been shown to decrease LDL by an additional 17 to 21% in patients that are already on statins. And the outcome study, clear outcomes, will be announced as a late breaker in the ACC 2023. It's typically really well tolerated. There have been, at least in some of the trials, something to keep in mind is if you have patients with history of gout, just something, just proceed with caution, but still well tolerated regardless. There have been some reports of hyperuricemia, gout, and tendon rupture, and this is an oral regimen. And if you have patients that still need more LDL lowering, there's a combo pill that on the market that is bempedoic and ezetimibe combined, and it decreases LDL by 38% on top of statin. Patients are already taking statin, and this drug has been FDA approved since early 2020. And the trials focusing on bempedoic acid have been the clear trials. So they've done studies on both patients that have persistent hypercholesterolemia, but despite being on maximal tolerated statins, and also those who have this condition but are unable, they're completely intolerant of statins. So they did this trials both in the US and much abroad. And so clear harmony and clear tranquility with the ones done in the US. And so in patients that are on maximally tolerated statins, there was about close to 16% decrease on these trials. And then on patients not on statins, so if they had to be on bempedoic acid, but they're not on statins, you saw about close to a 23% decrease from baseline. And this was after a 12-week period analysis. So we're going to pause right here and take another question that I want us to discuss or kind of ponder on. You can, if anybody hasn't been logged in before, just give you a second to log in. So the question I want to pose to you all is, if you have a patient, so say it's a 70-year-old patient, completely intolerant of statins and not at goal LDL despite being on evolocumab or ezetimibe, what would you do next? All right, let's see. I see some people saying they'd like to retrial statin therapy. Some would like to switch evolocumab to alirocumab. I'll just give it about to about a minute or so just to see, get more responses. We got about 7 earlier. And for people who need to log in, the login is poll@ev.com/BASH1 and just requires your UW login. And this is all anonymous. Right. There's someone would like to add on bempedoic acid. Switch evolocumab to alirocumab. Right. Once we hit 7, also I'll move. All right, so it seems like right now the prominent answer we're having from the group who's responded is they would like to switch to a different type of PCSK9 inhibitory human monoclonal antibody. So that's been our response. So I'll go over each answer to kind of explain the rationale. So with the term completely intolerant, these are patients that despite being on the lowest dose of statin, say they're on every other day regimen or lowest daily regimen, they're not able to tolerate it. So that's what we mean by completely intolerant. And the one thing with evolocumab versus alirocumab, what we saw is their LDL lowering potential is about similar. In fact, you might get it, at least on the studies, they found a little bit of a robust response with evolocumab. And the other thing I wanted to point out is with inclisiran, so I'm glad nobody responded with inclisiran. So if you have a patient on a PCSK9 inhibitory drug, you should only be on one of them, not both. So if a patient's on inclisiran, that means they were either started on or switched off. So usually if you have a patient, say, who's not, for some reason, not tolerating or the cost is too much evolocumab, you should switch them to inclisiran, never add it on. And that's and a lot of what I'm going to be talking about is based on the latest expert decision pathway, and they go through each diagram for different patients. So I encourage you all to check that out as well. So the answer I was looking for is the bempedoic acid. Because at this point, because the patient is completely intolerant, even with alternate dosing, they might be less inclined to try it. So I wouldn't necessarily retrial it. And evolocumab to alirocumab is about you getting the same type of effect, but with adding on bempedoic acid, you will get a different strategy for lowering LDL, and this strategy, it works up, a step above where status would have worked in the cholesterol synthesis pathway. So just to bring it all in. So to compare and contrast these drugs, statins are excellent in terms of lowering LDL, but like we talked about, because of a lot of misinformation or non-adherence, that's a big issue. But cost is great. About 6 of the 7 drugs that are currently available are generic. So cost consideration is another option, advantage of this. With the ezetimibe, it's really well tolerated, but at this level to lower your LDL is only modest. And with bempedoic acid, what's great, and I mentioned this earlier, is that they did trials on patients specifically that reported that they did not tolerate they didn't tolerate statin. So when they used bempedoic acid, they saw that these patients who said they either could not tolerate it, that they did well on this. So, but it's only modestly lowers LDL. And alirocumab and evolocumab, as well as inclisiran, these are all excellent for lowering LDL, but both of them have to be injected, and cost is going to be another consideration. What's nice about inclisiran is that it's only, once they get to maintenance dose, you only may need a Q6 months dosing, but we don't have the outcomes data yet to support its impact on cardiovascular events. So that's the main thing I wanted you to take away. And in terms of just to have a visual comparison of where everything stands with so this is a percent LDL-C reduction by various of drugs we just talked about. So with statin, it's anywhere from 50 to 68% lowering, and the other drugs is on patients who are already on statin. You see that you get the most impact from this PCSK9 and inhibitory drugs, but you still have modest effects from ezetimibe and bempedoic acid. So while these drugs are great to help you achieve or overcome some of the challenges in keeping patients on statins or achieving the goal, or and other risks that we have that we're trying to address, there's also another subset of patients I kind of want to quickly touch upon, which is that may need further lowering, and this is patients with familial hypercholesterolemia. So these are patients with autosomal codominant disorder. Usually they have a loss of function mutation that leads their LDL receptor not to be functional, which leads to increased LDL concentration of plasma. So for these patients, some drugs on the market, one of them is evinacumab. So this is a monoclonal antibody which targets protein called angioprotein-related protein 3. So the interesting thing about this drug is that currently there's no, it's unclear exactly how it lowers LDL, but we're seeing the impacts on many studies. What this protein mainly does is actually, it's involved in triglyceride degradation. And so the mechanism that's known about is that this protein actually is involved with VLDL processing and maybe inhibiting it. That could potentially be the reason that is leading to LDL-C lowering, but still being evaluated. So the nice thing about this drug is that its impact does not involve the LDL receptor, which is great because in patients with familial hypercholesterolemia, they don't have functional LDL receptors. So it's their ideal candidate. So right now, this drug is mainly on the market for patients who have homozygous familial hypercholesterolemia. And this drug has been shown to lower LDL by 49%. It's typically really well tolerated. I just mentioned some side effects there just to keep in mind things that patients have reported on clinical trials, but it's really well tolerated. But this drug has to be infused Q1 month, and patients need to come in for this. The other drug specifically thought for patients with FH is lumipipide. So this inhibits microsomal triglyceride transfer protein. So this is and in doing so, it blocks ApoB assembly, and this drug leads to about 40 to 50% decrease. But because this drug affects the transfer of triglycerides, one thing it's been shown to do is it has black box warning for hepatotoxicity, because they've seen that cholesterol built up in the liver has been an issue. And but this drug, like I said, mainly if say the first drug that evinacumab is not working, that's another alternative we can use on patients with homozygous FH specifically. The other one that I thought was neat was LDL apheresis. That's a way in which to selectively remove ApoB containing lipoproteins. And that's done extracorporeally, and it's done weekly to biweekly. And you see you see at least 50 to 60% decline in LDL. But this is now mainly available for patients with heterozygous and homozygous FH. One thing I want you to keep in mind is also all these drugs are very expensive, specifically because they're not, so apheresis is a way therapeutic, but like the earlier ones for FH, they cost as much as $30,000 a year, and also very niche drugs. So these drugs are kind of considered orphan drugs. I think we talked about a lot of drugs and mechanisms, and the goal is not to have you remember everything, but at least to reflect upon, what options you can use, and what some considerations to make when you're deciding to switching between the different drugs. I just want to take a second to pause and say, yes, we did cover a lot. And if you're up for it, we're going to talk a bit now about emerging therapeutics, which are now being studied mostly in animal models. All right, let's move forward. So we'll be talking about LDL-C targeting therapies that are being developed. So the ones I'm going to mention right now are the ones, gene therapies, the one people are most excited about. So gene silencing, so using either antisense oligonucleotides or small interfering RNA that target finding different targets. There's also gene editing, which is when you edit the genome without introducing a cut. So you just change it, for example, just a base. You also have gene delivery, which is using a vector to deliver, say, a healthy gene, and vaccination is another option, as well as small molecule inhibitors with different targets. What I don't cover now is the other. So this what's also being developed right now is non-LDL-C targets, such as apolipoprotein A1, apolipoprotein C3, as well as lipoprotein A RNA. I don't cover this, but that's also something that's being studied right now. So for the first one, so gene silencing. So we've kind of already started this right now. For example, inclisiran is a type of gene silencing mechanism because it affects PCSK9 expression. But what's happening right now in the pipeline is they're trying to target different parts of the lipid metabolism pathway. So with, for example, and I have this diagram to kind of explain how these work. So when it comes to antisense oligonucleotides, so ASO, they dielectrically interact with the mRNA, but they don't need a silencing complex to achieve this goal. So now there's a drug that's currently in phase 1 targeting PCSK9, and so far it's shown to decrease LDL by 68%, which when we saw PCSK9 with the other ones, we saw the most we got was maybe 60% before. And then with a small interfering RNA, this requires interaction with silencing complex to target the mRNA. And one drug that's being studied is targeting the ANGPTL3 mRNA. And it's currently in phase 2, but the phase 1 study has shown about 42% decrease in LDL. The one that's getting a lot of enthusiasm is gene editing. So the pioneers of gene editing, so specifically for CRISPR, which is clustered regularly interspaced short palindromic repeat. The pioneers, Professors Carpentier and Doudna, got a Nobel Prize in 2020, so Nobel Prize in chemistry for this. And so what's interesting about this is you're able to introduce a change in the genome, so you can change, say, for example, the adenine nucleotide to different nucleotide by just using this. You don't have to introduce a cut. So with other times when you have to do gene editing, you'd have to introduce a cut in the genome and then repair it. But this one, what's nice about it is that you can go in and just change one. And this comes in handy in patients that have, say, loss of function, say with patients that have familial hypercholesterolemia, they have loss of function in the LDL receptor gene expression. So you can introduce a base pair to bring about a change in that. So the way this drug works is there's two components. One is the guide RNA that recognizes what you'd like to change a base, and you have an endonuclease that does the cutting. So they did one study in primates, and they saw that after one injection, they saw about 80%, 90% decline in PCSK9, and the LDL declined by 60%. And when they checked 8 months later, it actually persisted as well. The nice thing about this therapeutic, if it comes into, the market, is that you wouldn't have to worry about adherence because patients just need to get it once. However, we don't know what the off-target side effects are. So that's still something that needs to be investigated. So there was a study that came out this year looking at the safety and efficacy of this CRISPR base editing therapy in monkeys. And what they showed is that when the monkeys received these one injection, about 480 days out, they still maintain that level of reduction in LDL and PCSK9. So PCSK9 went as down as low as like 83%. So like I said, the less PCSK9, the better in terms of decreasing LDL. And then because there's less PCSK9 in their bloodstream, there was less LDL concentration as well. So this study generated a lot of excitement, and it's now led to the initiation of the first human clinical trial in patients with heterozygous and homozygous, heterozygous familial hypercholesterolemia in patients with ASCVD and uncontrolled hypercholesterolemia. So the first patient it was 2022 is when they started this trial. So that's one that's been a lot of people in the lipid realm have been excited about. The other one is gene delivery. So what you do is if you have a pathogenic gene, you try and replace it with a healthy gene. So the way to achieve that is using a vector. So here would be the adenovirus mediated therapy. So one drug that's being evaluated as there's a recombinant of adeno-associated virus, which contains the human LDL receptor gene that's functional. So when they injected mice with this drug, they saw that there was about 65% progression of atherosclerosis compared to the baseline, which 65 being compared to, and that's in the control, there's 65% progression. And then in those that got the injection of the actual drug, they saw the regression by 87%. So, like the placebo was, atherosclerosis progressed by 65, and the mice that received this gene delivery, which is the healthy functional gene, they saw about 87% regression. So the one challenging thing with this is that when you saw in mice model, mice tend to take up mice genome tends to take up genes much better than in humans. So while you're seeing these results, so far they haven't been able to see that level of significant regression, but there's still an impact. Currently, there's an ongoing study on 9 patients with homozygous familial hypercholesterolemia, and trying to see, but the data is still not available. And this study is being done by a group at UPenn. So hopefully in the next year or two, or maybe a few years, we'll find results about this. And second to last one I want to talk about is vaccination. So the idea with this is one of them is peptide-based anti-PCSK9 vaccine. So what it does is bring about almost the response of what a PCSK9 inhibitory drug does. So instead of giving patients human monoclonal antibody, you kind of try to get the patients to have that innate response to it. So this peptide mimics the target sequence, and then the innate immunity recognize that as that being foreign, and that leads to an immune response. And so in one study in anti-PCSK9 vaccinated mice, they saw that LDL decreased by 50%, total cholesterol by 30%, and atherosclerosis went down by about 60%. The half-life of this drug is 4 months, but when they rechecked patients, it was seen that not patients, the mice, the therapy was lasted about a year. So if patients were say to get like vaccinations for lowering their LDL, they might require boosters every year just with their their flu vaccines. Get your flu vaccine and your LDL lowering vaccine every year. And last one is the cholesterol ester transfer protein. So that is so the function of this protein is to transfer triglycerides from ApoB lipoproteins to HDL and cholesterol from HDL to apolipoproteins. So by targeting that, you can potentially achieve decrease in LDL. And so what they saw is individuals with loss of function of the CETP, or it was linked to lowering of LDL. So this is not a newish drug per se. What's new about it is that we're still trying it. So there have been two trials on this. One was the first trial, they didn't see in a 2-year follow-up, they didn't see an impact in cardiovascular outcomes. And in the second trial, in a different drug, there was a decrease in cardiovascular outcomes and the risk in a 4-year follow-up. But this drug was actually staying in the adipose tissue longer. So there was concern that the drug action would persist longer than intended. So these two drugs were, their drug development was terminated. But right now there's a drug, obicetrapib, that is in phase 3. And currently what we have data on that is on their phase 2 trials. LDL was lowered by 27 to 44%. And so there's the ongoing outcomes trial for this is PREVAIL, and is looking at MACE in those with history of CVD. So key points I want you to take from this presentation is: one, statins effectiveness in cardiovascular events is unequivocal, but cardiovascular risk persists. Our statin use in patients are limited by perceived versus true intolerance, and ability to achieve LDL goal, and the residual risk despite meeting LDL goal. The other key point is that at least in our clinic population, patients who may not have FH, FDA approved drugs that we have in our pocket include ezetimibe, evolocumab, alirocumab, inclisiran, and bempedoic acid, and things that are being drugs that are being investigated right now include gene therapy, so different targets for gene silencing, different gene editing therapeutics, and using vectors for gene delivery, as well as vaccination studies, and trying new novel targets for the small molecules to be inhibited. I would like to thank Dr. Kelly Branch and Dr. Savita Subramanian with helping me with this presentation. They were very instrumental in making sure that I gave you all more concise, because if you saw the original version, it would be too long for everybody. So try to hopefully impart a few pearls that can help your clinical practice. I thank you all for staying with me during this time for this presentation. And I'll take any questions you may have. All right, I have a question.
Thank you so much for that. I think you mentioned there's an expert consensus about using a antibody-based PCSK9 inhibitor and mRNA-based PCSK9 inhibitor. What is that expert consensus based on? It seems like there are so many other potential development PCSK9.
So right now, what we have that's FDA approved for PCSK9 inhibition is you have evolocumab or alirocumab. What's nice about those two is that we have cardiovascular outcomes data. I'm just going to repeat the question to the Zoom group. So the question was, we have expert consensus decision pathway document that came out, and why we're choosing between the different PCSK9 and what the data is behind that. So to repeat, so with while we have these different drugs, the two drugs I mentioned, alirocumab and evolocumab, they have cardiovascular outcomes data showing their impact on not only lowering LDL, but also in terms of how they impact cardiovascular disease outcomes. So they're 5-point or 3-point the MACE. And with inclisiran, we still are we're waiting on data for that because the outcomes data is not anticipated for 2026 and 2027. So that's where it's based off. And we see a very significant decrease in LDL with these drugs. So the expert consensus decision pathway, what it helps providers is, if you take a look at that document, one goes over the different drugs that are currently available that were not mentioned in the 2018 cholesterol guidelines, but they also tell you, like, they have decision pathways and different charts trying to guide you. Okay, if you are at this point, what to use and why. And so with inclisiran, because it also targets the same PCSK9 as well, you wouldn't want the same, you should try another mechanism. So the diagram sometimes can have and or options, but I wanted to use this presentation as a way to explain the rationale. And I would actually say use one over the other. And so till the outcomes data comes out, we're going to have to wait, maybe see. Cost is going to be another consideration. But yes, I do agree. Inclisiran sounds very exciting because you only have to do it once they achieve maintenance, only once every 6 months, and then you don't have to worry about patients taking their meds or having any issues with side effects. And one thing I wanted to add about side effects is, even if the nocebo effect is there, whether patients have perceived or true effect, you still have to proceed with the assumption, and you can try to get them to the lower level of statin dose they can tolerate, but you still, perceived or not, you still have to address their concerns and change your clinical practice accordingly. Any other? Oh, okay. Let me see another question here. All righty. The first question, let me see. I see Dr. Dechek has 2 questions. If we can perhaps unmute. Actually, sorry, I think it's on the Q&A section. Let me pull that up. All right. There's a few questions here. The first question is, there are people in the longevity movement who are driving the LDL down to the teens with PCSK9 inhibitors. The Western diet, the normal our site is not being evolutionarily normal. Do you think that is the future for everyone? I do agree that the future will be lowering LDL as low as definitely the teens, because we've seen that there's an inverse relationship of LDL with cardiovascular disease outcomes. And now we have data from, the one I mentioned that just came out a week ago, supporting that further. And so, yes, I definitely do see that. So I think another way to think of it is thinking of LDL as a toxin. Let me see. The next question is if studies take out the unstable angina endpoints from PCSK9 outcomes, what is the reduction in the primary outcome? That one I don't have an answer to, but it'd be, I haven't parsed it out in terms of what the outcomes would be with the different endpoints. If you, like you mentioned, the unstable angina endpoints were taken out. And then see, and I'll just follow up with the next one. All should read this Lancet article on effective statin therapy on muscle symptoms and individual participant and data meta-analysis of large scale and randomized double-blind trials. All right, and then last one from Dr. Sotodenia says, terrific talk. Do all the different drugs have a similar efficacy profile on hard outcomes given their LDL reduction? For instance, for every 10 milligram per deciliter reduction, is the MACE reduction similar across drugs? Or drugs have non-LDL benefits that decrease MACE risk beyond their LDL lowering effects? If so, what are the ones with the biggest MACE benefit given a fixed LDL lowering? So the challenging part about that is I'm gonna go back to just mention that when we saw in our timelines that of the drugs we currently have, statins, we have outcomes data. With PCSK9 inhibitor monoclonal antibodies, we have outcomes data. But say with bempedoic acid and inclisiran, we don't have the outcomes data. So in terms of whether those drugs have an impact on MACE outside of just lowering LDL, that would be an interesting to kind of parse out once we have the outcomes data, because right now the impact we don't have, it's hard to compare. But right now, one thing, I'll just go back to the diagram I had put out earlier. this one. The main question seems is that as they're off target, and there are other targets that that these drugs may have. And I think that is definitely a possibility, but I can see if Dr. Savitha Subramanian is on to if she has any more input on that. But right now, from my end, I would say that we don't know the outcomes of these other drugs yet. What point? Go on. Yes, go on your question.
Thanks for the time. It was pretty awesome. You know, I think this would be somewhat of an off-target question, but we are going to enter an era soon. I mean, we are there kind of already where we have like efficacious monoclonal antibodies that are very expensive. And then we're going to have like amazing gene therapies that are very expensive. And we have statins that are cheap and efficacious, but they've been, their reputation has been smeared and it's sort of like unfixable, right? So I guess my question to you is, how are we going to deal with that? Like in 10 years down the line, how are we going to tell people you don't have to go to like a local market. You can try a Torva, and from a financial standpoint, how are we going to address that? And secondarily, this seems like yet another opportunity for discrepancy in a bias in medicine, whereby people who have a medical privilege, so to speak, are just going to go to all these specialized clinics like us, and they're going to get all the fancy stuff, and people out in the community are going to be stuck with statins for nothing, because they're quote unquote calling it. So a lot of that, but what are your thoughts?
No, that's a really good point, because one thing I forgot to mention is that from the data I've read, the research, the documents I've read is that true complete intolerance has been only rumored to be like less than 5%. So you're right, instead of just switching drugs that are more expensive, you're right. I think we need almost like a PR campaign to, help with statins reputation, because one, just because it happens with statins doesn't mean it can't happen with the other drugs. And more importantly, it goes back to your question about, these drugs, because they're high cost, so they're going to favor people who have the means to pay for them or means to go to a specialist. I think, and that's a perfect question. One thing I'm interested in is like public health outcomes. So if we, so prevention should be more than just on a patient level, it should be on the community level. So one thing that maybe we need to do as clinicians is go out in the community and work on, the biggest thing that popped up when we did the poll everywhere is misinformation. So maybe we need to be out there trying to decrease the misinformation, because when I was reading up for this presentation, there's a lot of things out there that, like you said, there's like that describe statins, and they start from people who can say they're providers, but they are quoting incorrect data and whatnot. So we really need to actually maybe, like you said, take a step back and try to work on, not just get excited about the new therapeutics, but try to make sure that we're changing the narrative of what statins are, because like a majority of them are generic, and all these other drugs, not only do you have to get one, have the means, but they also have these loopholes of like they make sure to get a prior auth or whatnot. So you're right. I think we shouldn't just get excited about the next ones, but also work on maybe the PR aspect of the drugs we already have that we know work. Thanks for that. So one more question.
So following up on that, maybe saying the thing that artists didn't say, is there any evidence, or it hasn't been suggested, that some of the purveyors of the more expensive options are behind some of the statin? There's information that's out there.
That's a good point. It could be that people may be trying to push for newer drugs and maybe just think, oh yeah, these drugs are well tolerated or whatnot. So you're not tolerating statins, try our drug. That's not impossible either. I don't have the data or information of what's out there. I mean, the few things I've researched have been on like people writing articles, like, I'm sure you've like kind of like those ways to improve your like cholesterol levels, but then they mention, oh, but these drugs are bad. So who knows who's writing those articles? It's unclear. But anyway, one thing I've always been interested in is that while we do a great job working with our patients, is I think it's important to go on to the community and kind of potentially investigate those kind of issues, because if we're not targeting our patients in different ways, not just on one-on-one, we see them in clinics, if we go out into the community, or they're working on trying to make sure what data they use to refer to or like is accurate, or also trying to fight like misinformation, trying to figure out where that's from. Is it from just people who have a theory, or people who are intentionally trying to discourage data news to promote something else? That's a good point. That's possible as well. Thank you for that comment and questions. I think we're over time in time, but thank you everybody. I appreciate you all coming here, and all of you who logged in via Zoom as well.